Take it away.
All right. Thank you, Adam, for that introduction. And thank you to all of our attendees today for your attention. As mentioned, I'm going to be talking about one of my favorite subjects today, which is pediatric hearing loss. I set this presentation up as kind of a walkthrough, starting with the external ear and working our way in. We'll be reviewing some of the basic anatomy and then some of the different entities that can be problematic in pediatric patients. So when we talk about the spectrum of pediatric hearing loss, as you are probably well aware, there are a lot of different potential underlying causes, including many that we aren't going to be able to see on imaging. There are several that we can be helpful in, however, and so being familiar with the findings in those cases is very useful to our clinical colleagues. It is always worthwhile to take a look at the ENT notes and audiology reports because having some idea of the type of hearing loss that you're dealing with might also give you some help with anatomic localization. So we'll start with the external auditory canal. So this is going to be about zero point 0.5 or 5.1 to 8 millimeters in pediatric patients. And it's going to be bordered anteriorly by an important osseous structure, which is the bony tympanic plate. The junction of the external auditory canal with the middle ear cavity is going to be a paper-thin line, the tympanic membrane. On temporal bone CT, it really should be paper-thin. If you're starting to see it very clearly, probably it's a little bit abnormal. We'll also just highlight here the scutum, which is going to be this sort of triangular junction between the external and middle ear cavity. It's going to be where the tympanic membrane inserts superiorly, and it's also just a landmark when we're talking about cholesteatomas, so another thing to be familiar with. So moving into the external auditory canal pathologies, I'm going to start out with congenital aural atresia, which is an atresia of the external auditory canal. And in this family, you actually have a few different flavors. You can have stenosis of the canal. You can have a partial atresia, where you have some part of an external auditory canal, but there's also a bony atresia plate, and the tympanic membrane is either not present or is rudimentary. And you can have complete atresia when you have full absence of the external auditory canal and a bony atresia plate, which is what I'm showing here. So highlighted in orange here, you can see the bony atresia plate bridging across where the canal should be. And when you're trying to differentiate between external auditory canal stenosis and atresia, that bony tympanic plate we talked about is going to be an important landmark structure. And so this is actually a patient who has bilateral congenital aural atresia, but they have full atresia on this right side and only stenosis on the left side. And what you can see, the difference, well, a few differences. One, we can see a very thin canal here, but more importantly, the presence of this bony tympanic plate, which is going to be the landmark that helps us differentiate between stenosis and atresia. You'll also note that external ear anomalies are fairly common when you have congenital aural atresia, and in this case, they've got microtia on the left side and a complete absence of an ear, or anotia, on the right side. Atresia of the external auditory canal can be managed in different ways depending on the hearing ability of the patient. So if they have pretty good hearing, they might be considered a surgical candidate for reconstructive surgery with a canaloplasty, a tympanoplasty, and also usually an auricle reconstruction. For patients who aren't candidates for that, there's also potential for active middle ear implantation or active or passive bone conduction implants. And so the Arshofer scoring system, which I have highlighted here, is something that system where points are graded based on the CT or, well, really CT appearance of the temporal bone for the involved ear. And this score is used by surgeons to sort of stratify patients into those who will have the best likelihood of a good hearing outcome after having reconstructive surgery. So patients who score above a 6 are going to be considered pretty good candidates for reconstructive surgery, whereas patients who score at 6 points are marginal, and really below that, patients are considered poor surgical candidates. And so those patients will be more considered for middle ear implantation or other hearing devices. You'll also note that there's only 2 absolute requirements for reconstructive surgery, one of which is having normal inner ear structures. So again, when we're reviewing our temporal bone studies for these patients, it's very important that we detect other potential anomalies in the inner ear because that will change the treatment plan for the patient. And then they also have to have some evidence of cochlear nerve function. So we'll often do MRIs in these patients as well, looking for presence of the cochlear nerve to sort of supplement this planning process. One other brief mention, and we'll talk about it a little bit later in a few slides, but as I have highlighted in the first case I showed you, in the case of congenital aural atresia, you often also will see malformations of the middle ear cavity. A lot of times the ossicles will be ankylosed to one another, as well as to the walls of the middle ear cavity and or the bony atresia plate. All right, so then a little bit of shifting gears here, but staying in the external canal. The other sort of common pediatric entity with the external auditory canal is going to be otitis externa. Generally, this is a clinical diagnosis, colloquially called swimmer's ear, and it is associated with swimming in up to half of cases. And this is basically inflammation of the soft tissues about the external auditory canal that can cause transient narrowing, most commonly caused by Pseudomonas aeruginosus, with a peak onset between 5 to 10 years of age. Okay, so now we're going to move into the middle ear cavity. Again, we're going to look a little bit at the anatomy, and then we'll talk about some of the potential pathologic processes. So going from superior to inferior, the middle ear cavity can be divided into the epitympanum, mesotympanum, and hypotympanum, with the epitympanum housing the uppermost portion of the ossicles, as well as the adductus edentrum of the mastoid, and the mesotympanum, more the malleus handle, as well as round window. And then hypotympanum really doesn't contain any of our anatomic structures, but is just sort of an air-filled space in the lower part of the ear cavity. In the coronal plane, again, just kind of looking at a few of the structures, we did talk about the scutum earlier, where the tympanic membrane inserts, and that is usually best assessed in the coronal plane. The tegmen is going to be the bony roof, and you'll have a tegmen mastoideum over the mastoid and tympanum over the tympanic cavity. You'll have presex space, which is a space that is usually air-filled in between the scutum and the adjacent ossicular chain, but will be one of the important spaces to check for cholesteatoma. You can also look on this view to assess position of the facial nerve, which should be a bit lateral to where the oval window sits. And this is my favorite projection for looking at the oval window. Usually it should sort of look like a flat-bottomed glass. When you start to lose this sort of flat bottom and get more of a triangular shape, that's when you start to wonder if you're dealing with a stenosis or atresia of the oval window. And we'll look at some cases for that as well. Finally, the round window and air-filled structure that is sort of vertical in the coronal plane and should be contiguous with the basal turn of the cochlea. The ossicles are also an important part of the middle ear cavity. And again, looking at this across 3 axial slices from superior to inferior, you can think about what the ossicular morphology should look like as an ice cream cone higher up, which is from the malleus head articulating with the incus body, and then the little part of the cone from the incus short process. As you go down, you'll have 2 dots from the long process of the incus and malleus handle, and then more inferiorly, it'll have a slight change in orientation, and you'll get this sort of like 2 dash-like appearance. The malleus is going to be comprised, again, of the long process, a neck, a head, very small anterior process, with the incus having the body that articulates with the malleus, a short process, a long process, and a small process inferiorly called the lenticular process, which is going to articulate with the capitellum or head of the stapes. The stapes then should have 2 crura and a foot plate, which will insert into the oval window. So here again, a little more anatomy. Then I promise we'll look at some cases. In the coronal plane this time, just kind of showing you anteriorly the malleus with an articulation with the incus. Here we can see the tensor tympani coming down and inserting onto the handle of the malleus. As we go more posteriorly, we can see the incus body and the long process coming down. And then finally, at the level of the oval window, you should see a right angle that forms between the long process of the incus and the lenticular process of the incus. That should really be about 90 degrees of an angle. the angle becomes increased by quite a bit and more obtuse, that can be suggestive of some sort of anomalous connection between the ossicles or the ossicles with the middle ear cavity, some sort of ankylosis that could contribute to the abnormal angulation. Okay, so now some ossicular pathologies, starting with ossicular dislocation. Ossicular dislocation is going to be more common than ossicular fracture and is a potential complication that we need to think about with temporal bone trauma. We most commonly see ossicular dislocations with longitudinal fractures, more so than with transverse fractures, but you can see them even in the fractures that are sort of oblique, so always important to take a look. Incudostapedial dislocation is going to be the most common type, which I have shown here. And this incudostapedial fracture can be really hard to see in the acute phase when it first happens. When there's a lot of hemotympanum around, it's very difficult to see the stapes at all, let alone the articulation between the stapes and the incus. So in a patient who's had a temporal bone fracture and has ongoing conductive hearing loss, it's worthwhile to consider re-imaging the patient after the acute period. So this patient actually comes back a year and a half later, still having conductive hearing loss. And now we can see with all the hemotympanum resolved that here we have the stapes capitellum, here we have the articulation, the incus, and you can see a clear gap between the two. The incudomalleolar fracture then is going to be the other type that we talk about, or dislocation. And this is going to be where you have the ice cream, which is going to be the head of the malleus, separating from the cone, which is going to be the body of the incus. Sorry, this is like moving forward on its own accord here. And so again, this patient was not called at the time of the acute incident and came back with ongoing hearing loss. So in the setting of a prior head trauma, particularly with a temporal bone fracture, definitely worthwhile considering repeating the imaging if the patient has ongoing hearing loss. Finally, stapedial footplate dislocation is something that comes up more in the setting of penetrating injuries. But if that does happen, there's a risk for perilimb fistula since the stapes footplate at the level of the oval window is sort of separating perilimb from the coming out into the middle ear cavity. So then just another example of ossicular dislocation here. So you can see an oblique temporal bone fracture coursing through. We can see here's the malleus, here's the incus, and there's very clearly a separation between the two. You can see that the articulation is also abnormal in the coronal plane, and then highlighting the complete disassociation of them in the oblique plane. Next, we'll move into congenital ossicular malformations. So these have an incidence of about 0.5 to 1.2% in children that have conductive hearing loss. Importantly, about 1 in 4 cases of ossicular malformations, or those that have malformation of the oval or round windows, occur as part of a clinical syndrome. So although you can find them in isolation, when you see an ossicular malformation, definitely go take a closer look at the rest of the temporal bone and the face for other anomalies that might suggest a craniofacial syndrome. Isolated ossicular anomalies tend to be unilateral, and if you are concerned about it, there are a few points you can use to help yourself. So one is just going to be loss of symmetry on the ossicular chain. So I like to reformat these so that I have them truly equal side to side to look for that loss of symmetry. Again, as I mentioned before, when you have that 90-degree angle, or what should be 90 degrees across the short lenticular process of the incus and long process of the incus, and its articulation between the lenticular process and stapes, when it becomes greater than 90 degrees, you start worrying that you have some sort of anomaly. And then finally, you want to see air kind of outline the ossicular chain within the middle ear cavity, so you can look for asymmetric spacing between the ossicles and the wall of the middle ear cavity. We'll look at a few examples of these to show a little bit better. The congenital ossicular malformations are sort of classified into 4 groups. And that tends to be related to the mobility of the stapes footplate and the ossicles that are involved. So you can have just stapedial fixation as its own group. That's going to be one that we really don't image very well. It's going to be much better determined by the ENT. You can have stapedial ankylosis, which is associated with other congenital ossicular anomalies. So we would be able to see some of these other anomalies You can also have ossicular chain anomalies with a mobile Stapes foot plate, and you can have aplasia or malformation of the oval and round windows. So then looking at some congenital ossicular malformations, I have on the top here some abnormal cases and on the bottom some normal images at the same level just to show you the difference. So in the first case, hopefully you can sort of see the malrotation here with the incus fused to the wall of the middle ear cavity. So I like to sort of draw that line around like in the normal case where I can see air all the way around. But here I can see that we lose the air. It's malrotated. The orientation is not quite right. And we also happen to see that there's an aberrant position of the facial nerve canal. This is an example of a patient with congenital aural atresia. Again, these patients do have a higher likelihood of also having ossicular malformations. And they do sometimes get this peculiar malformation, which has been called the boomerang configuration of the ossicles. And this is caused by sort of this fused dysplastic malleus and incus complex that have a sort of boomerang-like shape, and then deficiency of the incutostapedial joint and stapes capitellum. So see a little gap there between the ossicles and the adjacent stapes superstructure. A couple of additional examples. This is an example of a deficient lenticular process. So again, you have the long process of the incus and then the lenticular process of the incus, which will articulate with the stapes capitellum. And here you can see there's a short segment of deficiency in that lenticular process. Malformation of the stapes. So one that we can see is a monopod configuration of the stapes, where instead of having the normal two crura like you see here, you have a single crura that's inserting onto the stapes foot plate. And then some of the window atresia stenoses. Like I mentioned when we were talking about the normal anatomy, you really like your oval window on this coronal view to have sort of a flat bottom shape. And when you're dealing with an atresia case, it gets this more triangular morphology, which can be really helpful for trying to pick this up. You should also, on the axial view, not really see a bony covering here, which in the case of atresia, you can see a bony plate extending across where the window should be. Finally, although not always true, a lot of times when you have oval window atresia, you'll have an abnormal course of cranial nerve 7, and the facial nerve canal will actually go right over top of the atretic oval window. So it's much more medial in position than where it normally should sit. And then here's a case of round window stenosis. So although in this case, the round window is located where it should be, we see that on the right side, it's very narrow compared to what the normal width on the left side is in this patient who had unilateral conductive hearing loss. Shifting gears then to cholesteatoma, which is a little bit different flavor. So you can have cholesteatomas can be congenital or acquired, and what basically we're dealing with is a focus of keratin that's surrounded by stratified squamous epithelial cells. So congenital cases can happen anywhere in the temporal bone, and they're believed to be a result of an embryonic epithelial rest of tissue that just is located where it wasn't supposed to be. And they can be associated also with other anomalies of the first branchial remnants or abnormalities of the external auditory canal. Acquired cholesteatomas can be primary or secondary. Primary ones tend to classically occur along the pars flaccida, behind an intact tympanic membrane or in association with an intact tympanic membrane. And they basically sort of form where you have this little flaccid part of the membrane and it sort of forms a little pocket, and some of this epithelial material gets sequestered in there and then sort of becomes inflamed and can sort of grow and become destructive. They can also occur along the pars tensa, but the pars flaccida is going to be the much more common location. And then you can also have secondary cholesteatomas, which are going to start out sort of external to the middle ear cavity and can grow through a perforated tympanic membrane. And usually these are more often located near the pars tensa. So just an example here, this is a cholesteatoma involving the middle ear cavity as well as some sort of non-specific opacities in the mastoid. And when you're interpreting the CT in this case, it's kind of challenging, right? We see that the mastoid is sclerotic. We see that it's probably underpneumatized. and we see this non-specific opacity. But what's challenging on the CT is we don't have anything that looks definitely like erosive change. We have a very sharp looking sputum. We have the ossicular chain we can see. It's not clearly eroded. We don't see a Tegman defect. So interpreting this is challenging, right? You would probably put out some sort of report like non-specific opacity, clinical correlation with otoscopic examination, or consider MRI for further assessment. In this case is a really nice example of where MRI can add value for these types of questions. So when we look at typical bland diffusion, it should be very bright on the T2, whereas cholesteatoma is going to look very dark. And then we won't expect the cholesteatoma itself to enhance, but it might have some enhancement along its periphery. This is more helpful when you're trying to sort out if you're dealing with recurrent cholesteatoma or granulation tissue from prior surgery, while granulation tissue tends to enhance, cholesteatoma doesn't, so that can be helpful. And then finally, using a non-EPI diffusion sequence can be helpful, and you'll see that there will be restricted diffusion within the areas of this that are actual cholesteatoma. Okay, now we'll talk about tympanic sclerosis or tympanosclerosis. And this is basically inflammatory dystrophic calcification that occurs in the middle ear cavity. Myringosclerosis is sort of like a very subtle flavor of tympanosclerosis that only involves the tympanic membrane, whereas tympanosclerosis refers to involvement of more than just the tympanic membrane. Usually it'll kind of show up in the setting of recurrent otitis media, and once you have involvement beyond the tympanic membrane of sclerosis, you can start to have clinical presentation with conductive hearing loss. And on imaging, what we're looking for is basically calcifications in the middle ear cavity along places where they shouldn't be. There's too much calcification along the stapes, and whereas it's normally sort of pencil thin and not as dense as the other ossicles, it's much too dense. And we see additionally calcifications along some of the suspensory ligaments or tendons, as in this case, we've got superior suspensory ligament calcifications here. And then you might also see secondary findings of the chronic inflammation. So often you'll see that the mastoid is under-pneumatized compared especially to this case, which is more normal pneumatization. You might see a sclerotic-looking mastoid, and you get opacified air cells that are there. And then again, myringosclerosis, sort of a milder flavor. This may or may not have any sort of actual hearing impairment, but could be like maybe an earlier precursor of tympanosclerosis. And whereas your normal tympanic membrane should be this sort of a pencil thin line, I always tell my trainees that you could like just draw it with a pencil. And if it's any thicker than that, it's probably not quite normal. And here on the other side, an example of myringosclerosis, where you can see it's not like the membrane is super thick, but it's too dense. And we can see they've got a tympanostomy tube. They've probably had some issues with inflammation in the past. Now they have a little bit of mineralization along the tympanic membrane. Okay, so we talked about the external ear. We talked about the middle ear. Now we'll move in and look a little bit into the inner ear here. So looking at CT first, and kind of looking at a couple levels of the inner ear structures, we're mainly dealing with the cochlea, the vestibule, semicircular canals, vestibular aqueduct. Cochlea should have 2.5 to 2 3/4 turns, should have this nice open space at its base for the cochlear aperture, should have this sort of radiodense, almost bow tie shaped structure, the bony medialis. The vestibule, you should have your 3 dominant semicircular canals. Vestibular aqueduct should be smaller than the adjacent semicircular canal and should be less than 1 millimeter at its midpoint. And then the cochlea itself will have components. Sometimes you can see the spiral lamina in the cochlear turns on CT. It's usually imaged better by MR, but that will be separating then the scala tympani from the scala vestibuli components of the cochlea. This is the MR appearance. Again, MR is going to let us see some of the structure within the cochlea a lot better than we can see on the CT. But we're still looking at the same anatomy, so we still want to see the sort of spiral shape of the cochlea. The modilus should be sort of dark. Again, we can see that spiral lamina in the turns of the cochlea a little bit better, separating the scala tympani and the scala vestibuli. The MR is also going to allow us to look at the nerves within the canal, including the cochlear nerves, the facial nerve, and the vestibular divisions of the vestibulocochlear nerve. So the normal cochlea, as we mentioned, should have 2.5 to 2 3/4 turns. Usually average height of about 3.7 millimeters, average width of about 5.75 millimeters. The cochlear aperture should be greater than 1.4 millimeters. So this is something that you might be able to catch on CT. If you carefully check the width of the aperture and you notice that it's less than that, you might recommend an MRI, because when the aperture is too small, it often indicates that the cochlear nerve is either hypoplastic or completely absent. And then, you should have, as we mentioned, the sort of normal medialis cone in the middle and the interstellar septa extending out to sort of separate the turns. So here's a table that just kind of shows lots of the potential abnormalities of the cochlea. And we're going to look at some of these different malformations with case-based examples shortly. But one of the things I want to highlight, is that the treatment is going to be different for some of these options depending on what you're dealing with. If you don't have any cochlear structure, then you're going to need some sort of auditory brainstem implant. You're not going to be able to establish hearing with a cochlear implant if you don't have a functional cochlear nerve. Similarly, like hearing aids, not going to be very helpful if you don't have the neural structures to receive that information. As you go down to the sort of milder end of abnormalities, you can see that there will be some more treatment options. They may not even be considered for the brainstem implantation, but maybe cochlear implantation or hearing aids will become more relevant. So starting kind of at the severe end of the spectrum, and we'll work our way to the milder malformations. This is complete labyrinthine aplasia, sometimes called Mitchell's deformity. And in Mitchell's deformity, you're dealing with complete absence of all of the inner ear structures. So really early hit or problem where the otic placode, as it's supposed to be forming in the third gestational week, becomes arrested and so never forms any of the inner ear structures. And so when you look at this case, you can see that we have a middle ear cavity with some ossicles, and then absence of any structure medial to that resembles a vestibule, a cochlea, semicircular canals. And so this is complete aplasia of the labyrinth. You can have a very narrow sort of rudimentary IAC still present in some of the cases. Next on the list of milder severity, if you will, is going to be a rudimentary otocyst. So again, this is going to be like an earlier hit problem in fetal life where you have sort of developed a little bit of the otic placode that will stay as this remnant cystic structure, but you don't really have any other components of normal inner ear structure. And you also don't have a normal or any internal auditory canal. So on CT, this is just going to look like a little cystic structure. You'll see that there's no cochlea out where you would expect it to be, and no internal auditory canal. Moving then to cochlear aplasia. So we're getting a little more developed. We now have some semblance of vestibular semicircular canals, but still no cochlea. So this hit is usually a little bit later in fetal life, so maybe between like 3rd to 5th weeks of gestation. Again, some sort of arrest to the inner ear development. And in this situation, you have complete absence of the cochlea still, but now you have some formation of vestibule and semicircular canals, although they might still be sort of rudimentary or poorly formed. And you should see that the posterior internal auditory canal fundus should be along the superior aspect of the vestibule here. And then one thing to keep in mind with cochlear aplasia, if you're trying to differentiate it from labyrinthitis ossificans, you're going to have loss of the cochlear promontory, or not have any presence of cochlear promontory in the setting of cochlear aplasia, whereas in a case of prior labyrinthitis, you'll still sort of have the bump of the promontory. It'll just be all filled in with bone from the prior inflammatory infectious condition. All right, moving up, now we have some semblance of a cochlea. We're moving to the common cavity malformation. So in this situation, we've got sort of this dysmorphic, poorly formed cochlea that forms a common cavity with the vestibule and semicircular canals. You'll note that this cochlea is missing a lot of structure. It doesn't have internal architecture. It doesn't have any sort of medialis. And this is one of the sort of more common potential cochlear malformations. hit again pretty early in fetal life by around the fourth gestational week. Then we can move into the incomplete partitioning family of cochlear malformations. So now we're getting less severe. We're starting to have a cochlea that's clearly separated from the vestibule. So whereas with the common cavity, we don't have any clear separation between this cochlea and vestibule. As we move into the incomplete partition family, you'll start to see that the cochlea is really separate from the vestibule, but it still has some problems with its internal structure. So incomplete partition type 1, kind of more severe end of the spectrum, sometimes called the cystic cochleovestibular malformation. And this has been sort of likened to the appearance of a figure eight. So you have like the cochlea and you have the vestibule, and you kind of get this figure eight shape because of the separation between the structures. And you have the cystic cochlea that still doesn't have the proper internal structure. You have an absent medialis, you have sort of poorly visualized septa in between the turns of the cochlea. And then you have, separate from it, this sort of globular looking vestibule. These patients are potentially at risk for CSF fistulas. And so that's important to keep in mind if they decide to do a cochlear implantation for this patient, just to sort of warn your surgeons that there's a risk for that. They can also have risk for recurrent meningitis. And interestingly, they tend to have some areas of deficiency along the stapes footplate. So even if they aren't getting implantation, they can still actually have spontaneous CSF leaks or meningitis because of the deficiency in the stapes footplate, even without any sort of surgical intervention. Incomplete partition type 2 is going to be the most common cochlear anomaly that we see, counts for more than 50%, and the arrest is slightly later in fetal life, now getting towards the 7th gestational week. And with incomplete partition type 2, you've got a normal basal turn of the cochlea, but you've lost your differentiation in the distal part of the cochlea. So you lose the separation between the apical and middle turns. As a result, you get this sort of malformation that looks kind of like a baseball cap. You have a brim that's there from the normal basal turn, but then where the apical and middle turn should be separated, you just kind of have this central globular structure, and it forms kind of like the central part of the hat. So the medialis and spiral turn of the lamina are present only in that basal turn, and this can be associated with a globular appearance of the vestibule and an enlarged vestibular aqueduct. And when you have kind of all three together, then sometimes this is called the Mondini malformation. Last in the family for incomplete partitioning is going to be incomplete partition type 3, which is caused by an X-linked mutation in POU3F4. And this is associated with a mixed type of hearing loss. And this has been called the corkscrew cochlea. And you can kind of see why. It looks like this sort of spiral corkscrew, like you're opening a bottle of wine, right? And so the external structure of the cochlea is here and normal, and you have the interscalar septa. So it's trying to be sort of partitioned, but the middle medialis is still missing. And so that's why you get this sort of corkscrew appearance. And then you'll notice also that you're missing sort of the separation between the basal turn of the cochlea and the internal auditory canal. So kind of together, that is what gives you your corkscrew appearance. They tend to have a widened IAC, and this is another population who's going to be at risk for stapes gusher if they undergo surgical intervention. Another note for these patients is that this mutation has been associated with sort of dysmorphism or abnormality of the hypothalamus. So usually if you have an MRI, especially, go take a look. You might see some asymmetry or some fullness dysmorphism in your hypothalamus. Okay, then we'll talk about cochlear hypoplasia. So we talked about cochleas that basically weren't really formed at all. We've talked about cochleas that were formed and kind of the right size but lacking structure. And now we're talking about cochleas that are too small. And there's a whole spectrum of these anomalies as well. But in this situation, the cochlea you can clearly separate from the vestibule, but its external dimensions are smaller than that of a normal cochlea. And this has 4 types, with type 1 being kind of the most severe bud-like cochlea. Type 2, you have a small cochlea that has a normal outline, but sort of lacking internal structure and is too small. Type 3, you have a small cochlea and it doesn't have enough turns. And type 4, you have sort of a normal basal turn that's offset from a hypoplastic apical and middle turn, which is overlaps with the unwound cochlear appearance that we sometimes see in brachiootorenal syndrome. And so here I just have an example, and this patient has a type 3 malformation on the right. So the cochlea is too small and doesn't have enough turns. And then we look on the left, more of this type 1, just sort of bud-like rudimentary cochlea. Enlargement of the vestibular aqueduct is going to be one of the more common imaging findings that you'll see in pediatric patients with sensory neural hearing loss. And on CT, we're looking again at the diameter of the vestibular aqueduct. You can use the adjacent semicircular canal as sort of an internal control, but this should be less than 1 millimeter at the midpoint, or 0.9 millimeters at the midpoint, and then less than 1.9 millimeters at the operculum. And can see this then on MR, the actual endolymphatic sac will be also dilated and T2 hyperintense, whereas CT you're looking for the canal width. Next, cochlear nerve hypoplasia or aplasia. So this is an important finding to make because if a patient is being worked up for cochlear implantation and gets an implant and doesn't have a cochlear nerve, the implant is not going to work. And so this is definitely one of the areas where the radiologist can add value. And again, we mentioned that just seeing that narrow aperture on CT will already sort of raise your suspicion that you're going to have a cochlear nerve problem, but the MRI will clench the diagnosis. And so here you have an example of a case with a normal cochlear nerve and a normal aperture on the right, and on the left, you can see the aperture is very small and really diminutive little nerve there. And you can use this angle that acquisition that's sort of oblique along the axis of the internal auditory canal to look for the cranial nerves within the canal. And can remember from residency, you know, the 7-up, coke down mnemonic for the facial nerve being superior, the cochlear nerve being inferior, and anterior within the canal here, and then the superior and inferior vestibular divisions posterior in the canal here. Okay, so then shifting gears from the malformative and talking a little bit about labyrinthitis. So this is also going to be a process that involves the inner ear structures and is generally more post-infectious inflammatory. This is an important one to remember, particularly when you're dealing with pediatric patients that have had bacterial meningitis, because they can develop labyrinthitis as a complication, and if it's unrecognized, it can progress to a point that can be difficult to treat. So you have 3 stages of labyrinthitis. You've got an acute stage where you're just kind of going to see some enhancement, abnormal enhancement in the labyrinth. You've got a fibrous stage where you might still see some enhancement in the labyrinth, but you're also going to start to lose T2 signal in the labyrinth. And then you've got the ossification stage where you actually have bone forming in the labyrinth structures. It's really important to catch these cases in the acute or fibrous stage because that's going to be a stage where they can still receive a cochlear implant. If the patient is already at the ossified stage, the cochlea is too rigid and difficult to put a cochlear implant in. And so they're kind of beyond that of the treatment option at that point. So a couple examples here. This is a subacute case. So I have the CT here just to show you that you can't really see a lot of mineralization yet on the CT. But when we look at MRI, we can see that there's loss of the normal T2 signal in the labyrinthine structures compared to the other side here. And you can see that there's abnormal enhancement throughout the labyrinthine structures as well, compared to non-enhancement in the normal side. And then, unfortunately, not treated. And this patient came back a year later. And now you can see where the cochlea used to be. We just are seeing basically bone. You can sort of still see a little bit of the outline, but not much of the structure. Similarly, the vestibule, you can see part of it, but where the canals should be, you're seeing are all sort of filled in with osseous material. All right, some other potential abnormality to keep an eye out for pediatric patient would be schwannomas. They can happen along the facial nerve, or they can happen along the vestibulocochlear nerve. So here's an example of a facial nerve schwannoma on CT. What you're really just going to see is expansion of the facial nerve canal, and then on MR, corresponding abnormal enhancement. And then in the setting of NF2, you're thinking about schwannoma vestibular schwannomas, which tend to be bilateral, sort of avidly homogeneously enhancing and sort of extending out of the external auditory canal into the adjacent cerebellopontine angles. Lastly, I'd like to talk about a few syndromic causes for pediatric hearing loss, and then we'll take any potential questions at the end. So first syndrome we're going to talk about is brachio-otorenal syndrome. So this is an autosomal dominant syndrome, most commonly associated with mutation in EYA1. And they also, in addition to having hearing loss, as you might guess from the name, have branchial apparatus abnormalities, as well as renal anomalies, renal cysts, renal dysfunction, things like that. But the CT appearance for the temporal bone can be kind of striking, and so you might be the first person to sort of bring this up, particularly if you happen to have soft tissue windows and you also notice like a duplicated external auditory canal or some other sort of branchial apparatus anomaly on the same study. But for the temporal bone, what you're looking for, the cochlea, specifically with the EYA1 mutation group, has the sort of unwound cochlear hypoplasia appearance, where you have a sort of normal looking basal turn of the cochlea, but then the apical and middle turns are too small and they're really sort of not differentiated well from each other. And they're also kind of offset from the basal turn of the cochlea, which is why it's kind of been called unwound in appearance. There is like a subtler phenotype in patients that have a 6-1 mutation, where they just have sort of an extra thorny turn on the tip of the cochlea. So just something to be aware that that's also a potential appearance. The eustachian tubes can be really distended and patchless looking. So normally you can barely see the whole tube. And here you can see this gigantic air-filled eustachian tube. And they do have a propensity for ossicular anomalies and enlargement of the vestibular aqueducts. So I'm kind of showing you here some ankylosis between the ossicular chain and the middle ear cavity, a big vestibular aqueduct. And then interestingly, this is one of the syndromes that tends to have absence of the posterior semicircular canals, which is pretty unusual. Only a couple of things that do that. So if you do see that, particularly in conjunction with a big vestibular aqueduct and unwound cochlea, you can have a decent level of suspicion that you might be dealing with brachio-otorenal syndrome. Charge syndrome is another sort of classic temporal bone syndrome. And charge standing for coloboma, heart anomalies, atresia coena, renal anomalies, GU anomalies, and ear anomalies. It's important to note that the temporal bone anomalies are one of the most penetrant findings in charge syndrome. So again, this is a situation where you might be the first one to raise the diagnosis to the clinical team. You know, classically, people think more about atresia coena and colobomas and those things that might have been detected earlier in life, but those don't have as much penetrance. And so when you get the really unusual temporal bone with the findings that we'll talk about shortly, you might be the first one to raise the diagnostic concern. And charge is going to be caused by an autosomal dominant mutation in CHD7. And the classic finding you're looking for is a small vestibule with diminutive or absent semicircular canals. And there really isn't much else that does this. So if I have a case where I have almost no semicircular canals, as I'm showing here, like to me, this is a charge case until proven otherwise. They can have other anomalies. So you do want to keep a lookout. You might see an aberrant course of the facial nerve. You might see cochlea that's incompletely partitioned or hypoplastic. You might see ossicular malformations and ankylosis. You kind of see a little bit of that going on here, where the ossicle is sort of attached and ankylosed in here to the walls of the middle ear cavity. But what's really going to clench your concern on this CT should be the small vestibule and poorly formed, really small or absent semicircular canals. Hemifacial microsomia, now sometimes more commonly referred to as craniofacial microsomia, another disorder that involves abnormalities of first and second brachial arch derivatives, called hemifacial because it tends to be more severely affecting one side, although some prefer craniofacial since they can have bilateral involvement to a variable degree. But because you're dealing with first and second branchial arch derivatives, you tend to have abnormalities of the external and middle ear, as well as sort of the orbital floor and maxilla and mandible, kind of all the structures arising from those derivatives are too small or malformed. And so, as you might expect, you're going to have structures in the ear that are either not there or are too small or not formed. And so they have a high likelihood of having stenosis or atresia of the external auditory canal and middle ear cavity. This patient I'm showing you is a really extreme example where they have basically no external auditory canal, very little middle ear cavity, and then very stenotic atretic oval window. And in this case, you can see there's really no mandibular condyle in sight, and they had a very small ipsilateral mandible. You might have ossicles in milder cases that are dysmorphic or ankylosed to the middle ear cavity, or in more severe cases like this one, there may just be really no discernible ossicles present. And they often will have aberrant course for the facial nerve canal as well. 22q11 deletion syndrome, also called DeGeorge syndrome. This is an autosomal dominant syndrome as well. And the most common finding you're going to see here is less specific, but you will notice it in these patients, and that's having an absence of the bone island in the lateral semicircular canal or a small bone island. And you'll see often kind of like a incomplete separation of that lateral semicircular canal from the vestibule. If you look at the ossicular chain, this is going to be one of the conditions where you might have a stapes that looks too dense as well. They tend to have a dense stapes that has sort of a little bit widened appearance of the crura as well. You can have sort of milder cochlear anomalies or other ossicular anomalies, but this is going to be one where you're going to have to correlate with the chart. The imaging findings, although we do see them with 22q11, are certainly not specific only to that condition. One of the more common other disorders that'll give you this kind of appearance is going to be trisomy 21. Treacher-Collins syndrome. So this is another syndrome that's going to be causing issues of like sort of first and second branchial arch derivatives. But instead of being more unilateral, it's going to be more bilateral involvement. Also has autosomal dominant inheritance pattern. And there's a few different genes that have been implicated, but they have sort of this classic, like very small chin and lower facial structures caused by the mandibular hypoplasia. And they tend to have anomalies of the external and middle ear that kind of go along with that. So here we'll look at a case here. Again, it tends to be bilateral, and you'll see a small mandible. You might have small or absent zygomatic arches. You'll see there's no tympanic plates, and you've got full atresia of the external auditory canals. And often you'll also have sort of poorly formed ossicles that are ankylosed in these very like hypoplastic, poorly formed middle ear cavities. So with that, some references, and then happy to take any questions or go back to any slides if people have anything they would like to review further.
Wow, that was incredible. That was really awesome. Yeah, very, very thorough and very clear. I mean, definitely really great. If anybody has any questions, please feel free to put them in the chat. Yeah, I was curious about, so how do you make reformations yourself on all these cases? How often do you do that, or do the techs do it
Yeah,
well enough for you, or what's your normal workflow with that?
yeah. We routinely, we'll get the thin temporal bone CT. They should be sub-millimeter, usually like 0.6 or so. And routinely we'll get sort of coronal and then oblique reformats. So the axial plane should sort of be acquired in the plane of the lateral semicircular canal, and the coronal plane acquired then in sort of the plane of the superior semicircular canal, kind of perpendicular to the hard palate. And then the oblique is where it's a little bit trickier, I feel like, for our techs. Ideally, I like to get it so that I can almost see like the cochlea on end, and I can really look at that aperture well, and then also sort of have a full shot of like the superior semicircular canal in plane. And you also will have a really good look in that oblique plane at the calibrated vestibular aqueduct, and particularly the opening or the origin for it. But I would say, a lot of times I can use what they send. Sometimes I reformat. It kind of depends on what it is and my level of concern. If the planes that I have, I'm like, there's something funny, then I'm going to be making reformats. And I really like to reformat the coronals, especially for some of those subtle ossicular malformations. Like just being able to see the air around things and having it in the same plane really helps, particularly with like subtle unilateral anomalies.
Yeah, makes sense. Anybody out in the internet land have any questions, comments? I think this was a wonderful talk.
Oh, thank you.
Pretty clear, yeah.
Looks like we got a little something
Say
here. Oh,
thank you. Excellent summary.
no,
Yeah.
thank you. Thank you for joining.
Okay, well, if there's no other questions, yeah, I'm sure if anybody has any other questions, yeah, I'd be happy to answer anything. Dr. Faust, happy to answer anything, you know, at a future time. But yeah, we'll let everybody go and hopefully see everybody next month for next Peanuts lecture. Thanks again for this wonderful talk, and yeah, have a great rest of the day, everybody.
Thank you.